Thank you, Tina. I'll share my screen, I hope. Here we go. I hope that you can now see my first slide. It'll be very reassuring if you just tell me whether you can.
Yes.
Great. Thank you very much. Well, thank you for coming to my talk. As you can see, I'm going to talk about fluid therapy for adult ruminants. Tina's introduced me. If you have any questions as we go along, please feel free to ask them either by unmuting yourself or by using the chat function. I like to have questions as we go along. It helps me ensure that what I'm saying is relevant and useful for you. So if you have any questions or you want to challenge or ask about anything I say, please do. I'll just take half a minute to introduce Nimrod to you. I hope most of you know it. We concentrate on products for ruminants, horses, and poultry. The heart of our business is oral fluid therapy and clinical nutrition for adult ruminants and horses, and that comprises the select equipment, which we make, that you can see in the picture on the right, and the select formulae. We're also active in pharmaceuticals, in competitive exclusion for poultry, which is freeze-dried bacteria sprayed onto chicks in the hatchery, and in diagnostics. Right, let's broach our subject. I'd like to start with a question for you to reflect on for a minute, which is this. Dairy cows rapidly become dehydrated. Why is that? Give yourself a moment to think about it. And then I'll show you this slide, which shows us very clearly what the answer is. This bar chart shows data from a group of cows that were deprived of water for 72 hours. They were lactating dairy cows, and the blue bars show their loss of body weight each day in milk, feces, urine, expirations, and the orange bars show their loss of milk yield. And as you can see, on day one, these cows gave up 42 kilograms of live weight, but they gave up only 1.6 kilograms of milk yield. It wasn't until day 3 that they gave up more than half their milk yield. And by day 3, their cumulative body weight losses amounted to about 100 kilograms. So the reason that dairy cows rapidly become dehydrated is that we have selected them strongly to continue producing milk at the expense of their own hydration status. When do we need to worry about dehydration in dairy cows? Well, I think most commonly it is in endotoxemia. In endotoxemia, of course, we need to provide fluid to compensate for the expansion of circulatory space caused by vasodilatation, both generalized and in the infected tissues. You just need to think about the engorgement of the udder in a cow with coliform mastitis to realize that vasodilation in the local tissues is very important. And of course, it's a consequence of the action of lipopolysaccharide. When I was a veterinary student, we were taught that endotoxemia was caused only by lipopolysaccharide derived from the cell wall of gram-negative bacteria. But we now know that lipoteichoic acid from the cell wall of gram-positive activity has the same effect, acts as an endotoxin. So we shouldn't think of endotoxemia as being a condition which occurs or arises only in animals with a gram-negative infection. It can arise in animals with a gram-positive infection as well. And of course, in cows, we see it most often in mastitis, in metritis, and in acute rumen acidosis, where the flora of the rumen changes, in particular, as far as endotoxins are concerned, in favor of E. coli and lipopolysaccharide is absorbed from the rumen. We know that lipopolysaccharide is a risk factor for retained placenta, for displaced abomasum. It's a risk factor for metritis, that should be on the slide, and it's a risk factor for milk fever. It's not been elucidated why, but it is a very important risk factor, has a major influence on the incidence of these conditions. So an animal presenting with one of these conditions is quite likely to be in an endotoxemic state even before she has been subject to the effects of the presenting condition. The other set of indications for rehydration are, of course, the hypovolemic ones, and some of the most common fall into the categories of sequestration, where water is retained, for example, in the peritoneum in a traumatic reticular peritonitis, in the abomasal when there's an abomasal displacement, in rumen acidosis, where there's a tremendous increase in the osmotic potential of the rumen liquor, drawing water into the rumen, and in the straightforward fluid losses, diarrhea, ketosis, and pregnancy toxemia, which are essentially conditions where there's a diuresis, in surgery, and in heat stress. And of course, heat stress is not something we would practically treat as an indication for fluid therapy, but it is something we should recognize as being a compounding factor. So we may provide fluid therapy during times when cows are subject to heat stress, perhaps more readily when we see one of these presenting conditions than we would when they're not subject to heat stress. I think the most common hypovolemic indication is calving. As I'll show you, a period of hypovolemia is normal around calving, and whenever cows develop anorexia. And the reason why anorexia gives rise to hypovolemia turns on the fact that in ruminants, it is the rumen which is the most important site. Some physiologists say in the healthy animal it's the only site at which water is absorbed from the gut. It can be absorbed by simple osmosis, but more commonly, it's absorbed when the sodium pump creates an osmotic gradient. There's a sodium pump in the epithelium of the rumen, actually it's in the basal membrane of that epithelial cell, which creates an osmotic gradient by moving sodium from the rumen liquor into the rumen epithelium, and water follows it. Of course, it's not a great help to the cow or to the ruminant if water is simply moved into the mucosa. It needs to be carried away by the circulation, so the epithelial blood flow is important as well. The epithelial blood flow in ruminants increases within seconds as a consequence of the act of eating, and it also increases as the composition of the rumen fluid changes. So, for example, short-chain fatty acids and carbon dioxide both stimulate the epithelial blood flow. There's another reason why the contents of the rumen are important, apart from their effect on epithelial blood flow, and it's elucidated in this study that I'm going to show you here. This involved the transfer of rumen contents between sheep with rumen fistulae. The sheep were divided into two groups, and one group was fed twice in the day, and the other group was deprived of feed for 26 hours. Then the rumen contents were removed. The rumen contents from sheep that had been fed was put back into sheep. It was divided between sheep which had themselves been fed and sheep which had not been fed but had been deprived. The rumen contents of sheep which had been deprived, likewise, was divided between sheep which had been fed and sheep which had themselves been deprived. And then tritiated water, radioactive water, was added to the rumen, and the appearance of tritium or radioactivity in the portal circulation was monitored in the succeeding time. This shows the uptake of tritiated water from the rumen over time in the four groups of cows. The two upper lines joining solid data points show that the thing that is responsible for a high uptake of tritiated water is the fact that the rumen contents have come from a fed sheep. Whether or not that sheep herself was deprived of feed before the rumens were refilled. Whereas the two lower lines joining the open data points show that the much lower rate of appearance of tritium in the portal circulation, or the absorption of water, is seen almost identically in sheep which had been given rumen contents from deprived sheep when they themselves had either been fed or deprived. So what matters is the contents of the rumen. And the explanation for that is that the sodium pump requires an energy substrate. And that energy substrate is, of course, volatile or short-chain fatty acids. If we starve ruminants for 24 hours, then predictably, we see an increase in the sodium concentration of the rumen liquor because sodium is backing up in the rumen. The sodium pump can't clear it from the rumen. We see hyponatremia as the principal route for sodium absorption is closed, and we see hypovolemia as the absorption of water is reduced. So that shows that for normal hydration, cows must keep eating. I mentioned something about the commonness of dehydration at calving. This shows a plot of packed cell volume against time around calving in two studies. The one on the left is a French study, the one on the right is a Danish one. The upper limit of packed cell volume in the normal cow is 44–45%. In the right-hand study, you can see that on the day of calving, the cows were, on average, dehydrated with an abnormally high hematocrit or packed cell volume. You don't see that in the left-hand study, the French study, but that's because, unfortunately, the French investigators didn't take a sample on the day of calving. What you do see is that the shape of the curve overall is the same, and I'm sure that if the French investigators had taken a sample on the day of calving, they would have seen the same peak that the Danish ones did. So that's when endotoxemia and dehydration occur. What do we see? Well, there's just one study which records the clinical condition of the dehydrated ox. This is a Japanese study done in steers, and they were deprived of water, simple protocol, and they were found to have dry, cold mucous membranes and a sunken eye and an eyelid skin tent persisting for at least half a second. This was after 24 hours water deprivation, and it was found by weighing the animals that that was associated with a loss of body weight of between 5 and 10%. So there are two lessons for us to draw from that study. One is that the signs of dehydration are the ones we do expect, the ones we know from other species. And the other is that the loss of body weight, 5 to 10%, is something for us to remember when we're dealing with perhaps a 650 kilogram dairy cow. She may need 60 odd liters of water. We want to intervene early in these conditions because the cows involved are on a pathway which ends in death. When they start in endotoxemia or hypovolemia, there is a loss of arterial pressure and venous return. And of course, there's a compensatory response to that, which tends to maintain arterial pressure. That compensatory response we call compensated shock, and it involves an increase in heart rate and an increase in respiratory rate. That's limited by the delivery of oxygenated blood to the coronary circulation. And so there comes a point at which heart rate cannot increase sufficiently to provide the compensation. And at that stage, the animal goes into progressive shock. The delivery of oxygenated blood to the tissues is inadequate. Anaerobic metabolism at a tissue level begins. And the next step is irreversible shock, at which tissue necrosis results in toxin release from dying tissues. So we need to get in early in this pathway. what are our options for expanding circulatory volume? In any other species, we would think first about delivering isotonic fluid by the intravenous route. Cattle are often too big for that to be practicable or economic. In the 1980s, it became popular to use intravenous hypertonic saline. Of course, the advantage of intravenous hypertonic saline is that the volume required and the time required is much less than what we need for an isotonic fluid. Vets sometimes tell me they use intravenous hypertonic saline to make the cow drink, and perhaps cows do sometimes drink. There will be times when they don't, not least because one of the effects of lipopolysaccharide is to abolish the thirst response to hypernatremia. So we would be relying on something that we could have expected to fail if we thought we were doing this to make the cow drink. The reason for using intravenous hypertonic saline is that we have available to us a large reservoir of water in the intracellular fluid compartment. And if we increase the osmotic potential of the extracellular fluid, the osmotic potential will be equalized by the movement of water from the intracellular compartment into the extracellular compartment. In ruminants, we have an advantage because there's another reservoir available to us, and that's the rumen. So in ruminants, we can also move water from the rumen to the extracellular fluid compartment. Now, when this technique was first introduced, it was criticized for having a transient effect, and some American workers investigated how long the effect lasted if they also provided water into the rumen in the way that I've just described. So in this investigation, they used 40 milliliters of oral water per kilogram live weight. So, what's that? 26 liters for a cow. They used 5 milliliters of intravenous hypertonic saline per kilogram live weight. And they showed that that provided a rapid increase in circulatory volume, which is what we would expect. And the important thing about this is how quickly it works. They also showed that the effect persists for at least 3 hours. So it's a useful lifesaver. These days, except in the most extreme cases, we also have the option of giving isotonic fluids by the oral route. And this is the point at which I'd like to say something about our equipment for doing that. Here is a select pump drencher standing in the bucket. At the front of the picture, you can see the gag which lies in the cow's mouth. I'd like to draw your attention to the blue tip on the hose which lies in the gag. That blue tip is, as you can see, the shape of a bolus of food. So when the cow feels that in her pharynx, it will stimulate the swallowing reflex, which of course is what we want, because we want this hose tip to be swallowed into the esophagus rather than its passing into the trachea. This diagram shows our objective in passing the hose through the esophagus. We want the tip to reach the vertical dotted line that lies just behind the cow's elbow. That represents the level of the cardia, the first area of the rumen. If we push the tip too far, then we will be pushing it into or close to the rumen liquor. And when the rumen contracts, rumen liquor will be forced back up the hose. So I expect some of you have seen reflux come back through the hose when you've used this equipment. And when you've seen it, the reason for it is you've passed the hose too far. On the other hand, you want to pass it far enough, because otherwise you'll simply be pumping fluid into the esophagus, and that, of course, is a hazard for regurgitation and swallowing, drowning. So the hose needs to be passed to the cardia. Tip needs to lie just behind the cow's elbow. Here you can see somebody using good technique. He's got the cow in a crush. He has a halter on her, which is useful. The halter's not tied so tightly that he can't turn her head slightly to her right. He's put the gag into her mouth on the left-hand side, and on the right-hand side, you can see he's closed the nose tongue on her nose so that he can now pass the hose through the gag without having to hold the gag itself. You can also see it represented here, and in this picture, the hose has been passed through the gag, and that blue lever now needs to be turned clockwise. The blue lever locks the hose in position in the gag, and it's very important that you should use it, because if you don't, and the cow moves her head about during the pump drenching procedure, the hose can be drawn back through the gag, and the operator can find himself pumping into her esophagus or even her pharynx without being aware of it, creating a risk of drowning. Before starting to pump drench, in any case, the person doing it should check that the hose has indeed been swallowed rather than going into the trachea. And you can see a man here palpating the left jugular groove. That's where you will feel the hose if it's in the esophagus. He's standing on the right-hand side of the cow so that you can see what he's doing. I like to stand on the left and I push my fingers up into the left jugular groove, and then I feel the hard tubular structure in it. If you don't feel a hard tubular structure in it, next to the hard tubular structure of the trachea, in other words, two hard tubular structures, the cow has probably got the hose in the trachea and it needs to be withdrawn, and you need to start again. What are we dealing with physiologically? Well, a very large US study found that 10% of these animals are hypernatremic and hyperkalemic. Hypernatremia and hyperkalemia exist when there's a mild dehydration. They're important because they affect the cow's appetite, as you'll see later on. But as the dehydration progresses, the cows always become hyponatremic. Hyponatremia is a marker for the progression of dehydration. They also become hypokalemic. That's also a marker for the progression of dehydration. And very commonly, hypochloremic. Unlike calves, which generally have an acidosis, the dehydrated cow, the badly dehydrated cow, will have either an alkalosis or a compensated potential alkalosis that we can recognize from a high base excess. Very few of these cases are in acidosis, and those that are usually have a primary condition of acidosis. So you'll realize from what I've said that there's a physiological progression which starts with hypernatremia and hyperkalemia. Then these electrolyte concentrations are restored to the normal range, but then they become deficient. And in endotoxemia, these cows die in alkalosis. They don't live long enough to move back from alkalosis, as some of the hypovolemic ones will do, through anaerobic tissue metabolism and a normal blood pH to a condition of acidosis in which they die. So we're normally dealing with an alkalosis. And as I say, in endotoxemia, we're always dealing with an alkalosis. I'd like to show you something more about the pathology of endotoxemic shock. This is another Japanese study, 21 cows with coliform mastitis compared with control cows. And the ones with mastitis were divided into two groups. One group had septic shock, so collapse, depression, diarrhea. And the other group had signs of coliform mastitis, but no signs of shock. They were all given fluid therapy at the start of the study. Unfortunately, the authors didn't state in their paper what technique, what route, what volume they used. So we don't know much about it, I'm afraid. But they were treated in the way that you would treat a cow for endotoxemic shock now, with anti-inflammatories and so on. If we look at the physiological variables, you can see what I was talking about a few minutes ago, the compensatory response manifests as an increase in heart rate and respiratory rate, both in the cows in shock and in the cows that hadn't yet gone into shock. You can see an alkalosis in the ones that had gone into septic shock, abnormally high serum bicarbonate, high base excess, hypokalemia, and hypochloremia in the ones in septic shock. And the importance of preventing them from getting there is seen in the outcomes. 40% of the cows in septic shock died, and 5 of the other 6 required euthanasia, whereas all the ones that had received the treatment before they went into septic shock survived. Alkalosis, I think, is one of the reasons why they die so fast. Alkalosis is important for 2 reasons. Probably the less important reason, although an interesting one, is the effect of alkalosis in reducing free calcium ion concentration. And very often we'll be dealing with a cow which is already marginally hypocalcemic. Calcium in the circulation exists in one of 3 states. It may be ionized, represented by the green portion of the pie chart. It's the ionized calcium which is biologically useful. It's only the ionized calcium which is biologically useful. 40% of circulating calcium is bound to serum proteins, so that's not biologically active, and 10% of it normally is bound to serum anions. Of course, if we have this tremendous increase in the concentration of serum anions, tremendous increase in base excess, so some of that ionized calcium will move from the green compartment to the blue one, maintaining the dissociation constant for the calcium anion complexes. So if we're already in hypercalcemia, we're going to go further into it in alkalosis. The other thing that's important about alkalosis is that it reduces the dissociation of oxygen from oxyhemoglobin, so it compounds the hypoxia. Remember, we're already dealing with a condition in which the delivery of oxygenated blood to the tissues is inadequate, in which tissue hypoxia is already developing. This dissociation curve that you can see on the right is a plot of the percentage saturation of hemoglobin with oxygen on the y-axis against the partial pressure of oxygen in the environment on the x-axis. And if line B represents the dissociation curve in the normal animal, line A represents the dissociation curve in the alkalotic animal. You can see at a given tension of oxygen, for example, following the dotted line up from 27.5 millimeters of mercury, 50% of the oxygen sites in the hemoglobin will be occupied, half of it will be dissociated. But if we allow our eye to run up to a point on curve A, you can see that perhaps 75% of the sites for oxygen are still occupied. In other words, only half the oxygen that would have been released has been. That's the consequence of alkalosis, less release of oxygen in the tissues. And I think that's why alkalotic animals die so fast. Alkalosis has a relationship with hyperchloremia. This is something that was demonstrated quite recently, and it's a really interesting and elegant study which was done. These American investigators, Luke and Galler, demonstrated that a chloride depletion alkalosis cannot be corrected without chloride. They worked in rats and they worked in man. The first thing they did was to use diuretics to produce a chloride depletion alkalosis, and then they treated the hypovolemia that had been induced by the diuretics by providing volume, by adding circulatory volume without chloride ions. They found that they were able to restore mean arterial pressure, but the alkalosis persisted. They then repeated the experiment, but instead of providing adequate volume expansion, they just provided chloride ions. And in those patients or subjects, they corrected the alkalosis even though there was still an abnormally low mean arterial pressure. And they went on to demonstrate that the explanation for their finding is the existence of a pump called pendrin in the epithelium of the cortical collecting duct of the kidney. Pendrin allows the excretion of bicarbonate ions from the epithelial cells in exchange for the absorption of chloride ions from the tubular fluid. And what this picture shows on the left is a representation of the failure of bicarbonate excretion where the chloride concentration in the tubular fluid is inadequate. And on the right, a representation of the execution of bicarbonate excretion proceeding because there's sufficient chloride ions in the tubular fluid to allow the exchange. Right, I think that's enough biochemistry and physiology. Let's go back to another observation that we see in the field in dehydrated cows. This is the study that I showed you at the beginning of the talk, and I'd like to add now some more data from the study to the chart. Those gray bars show daily dry matter intake in the cows, and as you can see, unlike milk yield, dry matter intake is very susceptible, very sensitive to dehydration. In the first 24 hours, dry matter intake was already 19% less than it was in the control cows. And by day 3, in cows which still had a worthwhile milk yield, dry matter intake had gone down to just over 1 kilogram. The explanation for that finding, and I've already mentioned it, is the effect of dehydration on the rumen fluid tonicity. You'll remember that the first thing that happens is that we tend to get hypernatremia and hyperkalemia. So the osmolarity of the the extracellular fluid rises, and the osmolarity of the rumen fluid will mirror it. In this study, working in fistulated cows, the investigators monitored the osmolarity of the rumen fluid. They had 3 groups. Here's the osmolarity of the rumen fluid over 24 hours, or almost 24 hours, in their control group. They had a group that they called their deprived cows, and that group had its water supply turned off after the 5:30 sample had been taken and spent the rest of the experiment without any water. And as you would expect, the osmolarity of the rumen liquor in those cows rose to about 310 milliosmoles per litre. The third group of cows in their study, they described as their infused cows, and that group had its water supply taken off after the first sample was taken. And then after the second sample was taken, water was piped into the rumen through the fistula from a hose pipe. After the 2 o'clock sample, the 1400-hour sample had been taken, the water was turned off again. Here you can see the effect of deprivation of water and increasing osmolarity of the rumen liquor on feed intake was substantially less in each of the monitoring periods in the deprived cows. And what's interesting is that here you see the effect of whether or not water is provided. So in the infused cows, when water wasn't provided, the results were very similar to the feed intake of the deprived cows. But when water was piped into the rumen, restored, that's the period 10 until 15:30, feed intake came right back up, slightly better than controls. When the water was switched off again, it started to fall less in the last period. So that's another reason why dehydration is important. I think we can see now really that we're dealing with 2 kinds of consequence, aren't we? One is that, and the other, which is also important, is a reduction in dry matter intake. And it's important because we know it increases the risk of disease. In particular, it increases the risk of metritis, subclinical ketosis, and almost certainly left displacement of the abomasum. So I hope I've convinced you that it's worth treating endotoxemia and hypovolemia. What are our objectives if we seek to treat it? I think the most important by far is increasing circulatory volume and mean arterial pressure. In the early days of our advocating fluid therapy for cows, people used to ask us whether we'd done any trials to prove that it saved their lives. And the answer is no. And the answer is also no to a very similar question: have we done any trials in man to prove that it saves people's lives? And we haven't. We rely on anecdote. Here is a report from a paper recording the treatment with intravenous fluids of a cholera patient. She'd apparently reached the last moments of her earthly existence. And when the intravenous infusion had been given, every feature bore the aspect of comfort and health. This patient recovered. The person who wrote this paper was writing essentially a review of his experience, and he did say that some of his cases failed, and he attributed that to providing an insufficient volume or to intervening too late because the condition had progressed too far. And it's that kind of anecdote that we still rely upon to justify the use of fluid therapy, both in man and animals. We've known these things for a long time. That paper was published in The Lancet in 1832. Let's go back to our options. We want to increase circulatory volume. Option 1, generally not practical. Option 2 is the one we use if we need things to happen very quickly. And option 3 is the one that I would say we should use routinely. I think our next most important objective is to correct the hyperchloremia so that the cow can escape from alkalosis. We can do that with intravenous hypertonic saline, of course, or we can do it with an oral electrolyte solution. If we're doing it with intravenous hypertonic saline, as you can see from those figures there, what we provide as chloride is much more than the chloride deficit in the worst case of endotoxemia with septic shock that I've been able to find in the literature. So we've got a generous provision of chlorodynes. Our next objective is provision of sodium so that added water is retained in the extracellular fluid instead of being lost to the intracellular compartment. And whether that's necessary depends upon the sodium concentration in the rumen liquor. If the cow's been anorexic and sodium is backed up in the rumen liquor, then it may not be necessary. On the other hand, if anorexia has not been a major factor in the dehydration, there won't be sufficient sodium in the cow, be it in the rumen or in the circulation, so we need to provide it. Again, intravenous hypertonic saline or an oral electrolyte solution containing sodium. For the cow which has been anorexic, we should be providing the conjugate base of a volatile fatty acid. That'll improve the absorption of sodium and water from the rumen by providing a substrate for the sodium pump. And that's why in some formulae we use a propionate salt as the principal component of the electrolyte formulation. We may want to replace potassium. Certainly advanced cases, severe cases, animals with a condition like a displaced abomasum will be hypokalemic. Reason for replacing it is twofold. One is that hypokalemic paralysis is recorded in man and in cows. And an anecdote that comes to us from time to time is the downer cow that had had plenty of calcium but didn't stand up until she was pump drenched with a formula containing potassium. We've heard that a number of times. And it's absolutely understandable when we know that hyperkalemia is a cause of paralysis, that hyperkalemia can be responsible for some cases of downers. The other reason for replacing potassium is that it's important for the normal motility of smooth muscle, and in particular, it's been shown that in a hypokalemic medium, the contractility of smooth muscle cells from the abomasum is markedly reduced. So we would expect replacing potassium to reduce the risk of a left displacement of the abomasum, which will be a consequence of the loss of abomasal motility in the hypokalemic animal. Correcting the alkalosis, which we've already talked about, will be helpful because one of the factors in the hypokalemia in these dehydrated animals is the movement of potassium into the cells in exchange for hydrogen ions that have moved out of the cells into the extracellular fluid, tending to limit the acid-base abnormality, tending to limit the alkalosis. If we correct the alkalosis, that allows hydrogen ions to move back into the cells and potassium to move out of them. But nevertheless, it's rational to include potassium in an oral electrolyte solution as well. Incidentally, when I'm giving this talk in the Netherlands, which I do sometimes, I always point out that they shouldn't add potassium to the animal if it's a goat with Clostridium enterotoxemia, because those animals are actually hyperkalemic, and hyperkalemia is a predictor of mortality. But I don't expect you to deal much with Clostridium enterotoxemia in goats in Northern Ireland. Finally, we should remember to sustain plasma calcium and magnesium concentration, because if we add water without calcium and magnesium to the extracellular fluid, we will be diluting calcium and magnesium in the plasma and indeed throughout the extracellular fluid. And we don't want to do that. If you think about adding 60 liters of water to a dehydrated cow without calcium and magnesium, you can see that that will have a very substantial effect of diluting existing calcium and magnesium. So we should always include calcium and magnesium in an oral electrolyte solution in at least physiological concentrations. In some of our formulae, we include them at much higher concentrations, but we always include them in at least physiological concentrations. So I hope that gives you lots of good ideas for things to do. When you're doing them, you should keep in mind some warnings. Always use warm fluids. It's intuitive, of course, that we would want to use warm fluids for a cow, but it's also physiologically rational. If we use cold fluids, we'll chill the cow. Her response will be an increase in basal metabolic rate and the needless oxidation of glucose. And of course, that is going to make her more liable to go into hyperglycemia and hyperketonemia. She may very well already be hyperketonemic in any case. So always use warm fluids. Always check that the hose has been swallowed before giving any fluids. And don't pump drench a cow in lateral recumbency or in unstable stainal recumbency. As I said earlier on, fluid that's in the esophagus is next going to be in the lung. So we can't afford to pump drench cows in lateral recumbency. We're going to drown them. Our formulae, the select formulae, are designed to be made up in 20 liters of water per sachet. Doesn't matter if you make them up in a bit more water, a little more water, but never underdilute them, because if you do, you'll be adding a hypertonic solution to the rumen, and you've already seen that that has quite a powerful effect in suppressing feed intake. A couple of our formulae, Select Off Feed and Select Fresh Cow 500, contain a lot of calcium propionate. So use only one of them in 12 hours, because 2 sachets would be quite close to the toxic dose of calcium for a cow. I'm pleased to tell you we've never had a calcium poisoning, but I don't want to have one either. We've had a lot of theory. Let's look at a few practical cases to close, so that it gives you an idea of what you're actually going to do in a given clinical circumstance. So here is an imaginary case of mastitis, which calved a week ago. As you can see, this animal has a fever, it has a high pulse, it has a serious dehydration. This is an animal which is in trouble, pale and tacky mucous membranes, might be dead by tea time. This is the kind of case that I would recommend you treat with intravenous hypertonic saline. And to get value from the intravenous hypertonic saline, you need to pump oral water into the rumen. And not electrolytes, because you want a steep osmotic gradient from the rumen liquor to the extracellular fluid. We know that this expands circulatory volume for at least 3 hours. I would say this case should be re-examined after 4 hours, and she's probably at that stage going to need to be pump drenched with 20 litres. Bearing in mind the severity of the condition, I expect she's probably gone 24 hours without eating much, if anything. So I would suggest that we give her a propionate-based formula. In this case, that'll be Select Off Feed. That's the one with a brown band on a sachet. And because she was so profoundly dehydrated, then I think unless we find that the dehydration has been substantially alleviated, I'd probably want to give another 20 litres of a simple sodium chloride, potassium chloride formulae. And that would be Select Restore, which is the one with the green band on it. And incidentally, that's palatable, so that can be quite useful in circumstances where you or where the client doesn't have a pump drencher on hand. Let's look at another case, another mastitis, and this is even worse because this is in lateral recumbency. And it's clearly in septic shock. It's got diarrhea, it's got a high fever and a high pulse. So this is really in a very bad state. We can't pump drench it unless we can stabilize her in sternal recumbency. If you can prop her up between two big bales, then she can be pump drenched. But if she can't be propped up between two big bales, then she shouldn't be. So then you're left with isotonic intravenous fluids, and it's been shown that the best intravenous fluid to use is a 1-to-1 mixture of Ringer's solution and 2.5% glucose. I always used to imagine that nobody would actually have this, but I've discovered in Greece, where we have a new distributor, that the vets are routinely using intravenous isotonic fluids composed of Ringer's solution and 2.5% glucose. So there are some people who do that. Or maybe it's just got to be euthanasia. But don't drown the cow, because otherwise the death of the cow is going to become your fault when it needn't have been. Right, another case. This is a suspected displaced abomasum calved 14 days ago. Again, an anorexic cow. She's got a slightly elevated pulse. She's got a fairly serious dehydration marked by the eyelid skin tent. She stopped eating, got a sunken eye. The first thing we're going to do is correct the displacement. But she's got a bad dehydration, so she's going to want at least 40 litres of fluid. And again, because she's been off food for quite some time, I'd use Select Off Feed, and I'd use Restore as well in the 40 litres. Select Off Feed also contains gentian root, which is an appetite stimulant. It's been shown to be an appetite stimulant in ruminants quite recently. We've spent 150 years believing it was without it having been demonstrated, but it has now been demonstrated. And these animals very often have been ketotic to a degree. Hyperketonemia is a well-known risk factor for a displaced abomasum. If they didn't start off in hyperketonemia, they almost certainly went into it because the cow stopped eating. So you might well want to consider giving her glucogenic energy substrate in the form of glycerol propylene glycol. And if she's worth it, you might want to consider transformation. You might want to consider transformation because these cows that stopped eating lose a substantial proportion of the rumen flora. One more case. This is a metritis, purulent uterine discharge, calved a week ago. She's eating, she's got a low fever, she's got a modest dehydration. You're going to want to give her antimicrobial therapy. You're going to want to give her a non-steroidal anti-inflammatory. Her dehydration needs treating anyway, but it's particularly important to treat her dehydration when you use a non-steroidal anti-inflammatory, because as you'll know, and you'll see it on every data sheet for a non-steroidal anti-inflammatory, it's contraindicated in the dehydrated animal. And the reason it's contraindicated in the dehydrated animal is it reduces the renal perfusion, it reduces the circulation in the renal artery, and we can end up in acute renal failure. So very important to correct the dehydration when we're using a non-steroidal anti-inflammatory. 40 litres of Select Restore. She's still eating, she doesn't need off feed. She just needs a simple sodium chloride, potassium chloride formula with calcium and magnesium. So that's the end of my talk, and I think my simple message is that rehydration saves lives. I expect you all came to the talk knowing that in the first place. I hope that a few of you feel that you know a little bit more about why that's the case now, and I can see that you've been saving up your questions, so do please ask them now. Or you can type them in the chat, of course.
Mm-hmm. It would be interesting to know out of the people this evening whether anybody does use intravenous hypertonic, because we did another talk recently and somebody said that they'd been taught that they should more often.
Yeah, we did, didn't we? Yeah. Yeah. Well, it doesn't look as though anyone does. Unless, of course, everyone switched his camera off and gone for a cup of tea, which is also possible.
Oh, there's Nigel.
Yeah. No, I would be a fan of Restore, and I don't use hypertonic that while often. However, well, if you were using hypertonic, I know I've been listening, you're more or less saying leave it 4 hours, come back and give her a Restore. But some farmers want the whole works, and they would say if you didn't put in the powder, you know,
well, I think
they would think that helps. But how bad is it if you did put in the Restore? No, I don't.
I mean, if you put
if a colleague does, but I don't.
If you put the Restore in at the same time as the intravenous hypertonic saline,
yeah,
the only harm you're going to do is reduce the efficacy of the intravenous hypertonic saline, reduce the, and what you'll probably do is reduce the duration in which you expand circulatory volume. You know, it's not going to kill the cow. It's just going to make the therapy less effective. I think, you know, if you've got a client who wants to see some powders going into the cow, I think what I would be inclined to do is pump drench her with water to start with, then give the intravenous hypertonic saline, then fiddle around a bit and give her the injectables. And by then, you know, 3/4 of an hour's passed, and the intravenous hypertonic saline will have done a substantial part of its job. And I think that's the point at which to pump in another 20 litres with some Restore in it.
That's okay. That's fine. That's fine. Just want clarified whenever the experts were here, just that I should record it for my colleague, by the way.
Yeah.
Whenever you're putting in a hypertonic saline drip, is it important to put it in fast?
No, I mean, I don't think there's any merit in putting it in fast, and people often boast to me about how fast they can do it. But what you can do, of course, is increase your venous return too much and overload the heart, and you know, stop the heart. So
I've heard of some people pumping it in with a pump. I just let it run under gravity, and I was just thinking that you can see it.
There's no merit in pumping it in fast. There's only hazard. To be honest, people seem to get away with pumping it in fast, so perhaps I shouldn't overstate my case, but certainly in theory, there's a hazard in putting it in too fast.
Okay.
I use 3 litres of hypertonic saline, but one of my colleagues uses 5. Is there a downside to that above your dose rate of 5 mils or whatever?
I wouldn't think there's a downside to it. I can't think what, within reason, I can't think what the downside would be. I suppose you'd always be, I suppose that the downside might be that you might create a bit of I just wonder what effect it would have. The brain is very sensitive to tonicity. So whether you would be in danger of drawing too much fluid from the intracellular compartment, I don't know. I suspect if if it was going to cause a serious problem, he'd have seen it. In terms of fluid therapy, I don't think it matters if you give an extra couple of liters.
Okay, thank you.
Keith McKeon's box is lit up, so perhaps he's going to say something. No, okay.
I think it's our clock chiming. Apologies.
I wondered what it was.
I was going to ask, what would be the maximum volume you would pump into a cow at any one time? Normally would be 40 litres, but
that's a good question. The use of 60 litres is recorded in the literature.
Yep.
The use of 60 litres is rational. If the cow's lost 10% of her body weight, and she may well have done, as you've seen, then 60 litres would, in some cows wouldn't even replace the 10%. And I've never heard of it causing any problems. I don't think you'd want, if the cow had a full rumen, you wouldn't want to pump 60 litres in. But these cows don't have a full rumen. If it's a case that merits 60 litres, the cow is not going to have a full rumen. So that would be what I would recommend as a working maximum. And people do give 60 litres from time to time, I know.
Yeah. No, it was interesting you said that you would only use one sachet per 20 litres and only one sachet at a time for the calcium levels. So I would sometimes, if I was given 60 litres, I may put in 2 sachets, but probably one's enough, and using the Restore instead.
I was going to say, I would make up the extra with Restore. If you give 1 sachet of off feed in 20 litres, that's perfect. If you give it in 25 litres, that's also fine. If you give it in 60 litres, you run into this problem of diluting calcium and magnesium. So I think that's probably the most important reason for making up the extra with Restore, as you say. And if you've got away with giving 2, that's fine, but I'd probably rather not have the risk.
After pumping after an LDA, when you're pumping, you put in an off feed. Would you ever put in like potassium salt as well?
There's plenty of potassium in off feed and Restore. Frankly, there's probably more potassium than you really need. There used to be less potassium in Restore a long time ago, but there was some pressure from vets to have more. I'm going back 10 years now. So you don't need to give extra potassium. These formulae are generously provided with potassium.
Thank you.
Well, if anybody thinks of a question in the coming hours or days, if you wake up in the middle of the night thinking that what David Rennie said must have been nonsense, because please get in touch, send Tina an email, send me an email, send the office an email. We're always very happy to engage with you and discuss these things and give you our advice.
Thank you, David. If people are too shy to turn their cameras on, I wonder if you could just use the reactions for a thumbs up if you would like David to do another talk later on in the year for you. There's a follow-on to this one, which is clinical nutrition. Thanks, Joy. Thanks, Kevin. Okay, I'll try and get that booked up for a little later in the year for you. Thank you. Thanks very much for attending this evening. If you would like a CPD certificate, we can certainly provide one for you. Just text me or email me and I'll get that arranged.
Good. All right. Well, thank you all very much for your attention.
Thank you. Nice to see you. Take care.
Good night.
Thank you. Bye bye.
Bye.
Thank you. Thanks very much. Thank you.
Bye.